Alrighty, what's going on, everybody? It's Alex here from Aleks Physio. So today we have a special guest here. We have Dr. Emil Hashem on the line with us. So today we're going to be chatting a little bit about low back pain and surgery and everything with regards to it. Dr. Hashem is a orthopedic surgeon practicing in London, Ontario, Canada, and he's going to give us a little bit of a background more on who he is and kind of where he's at right now with regards to his career. And then we're going to dive into asking some questions for Dr. Hashem, and he's going to let us know what his thoughts and opinions are on some things, as well as what some of the research is saying. And then we're just going to have conversations and trying to elaborate on some additional subjects as well. So today we're just going to be talking more so about the spine, specifically the low back, and then we're going to we'll see how it goes and then progress into other topics in the future based on how it goes for today. So first off, welcome Dr. Hashem, Dr. Emil Hashem. How you doing today, buddy?
Hey, I'm doing excellent. Thanks for having me. Just as a clarification for your viewers, I'm not in full practice just yet. I'm just about to start my last year of residency training, and we're actually going to find out next week what our subspecialty fellowships are going to be. So it's a pretty exciting time, but just wanted to make that clarification, just finishing up my last year.
Yes, sir. Yeah, good call. And then Dr. Hashem can chat a little bit about the kind of how it works with regards to the residency system, and then how you progress from medical school to residency to being able to call yourself a surgeon, I guess. So yeah, before we continue and kind of ask some of the questions specifically, why don't you just tell us a little bit about who you are and kind of maybe a little bit about your journey into where you are now and where you currently are.
Yeah, sure. So, I mean, right now I'm finishing, like I said, just in my last, about to start my last year of residency training in London, Ontario. So I'm part of the Western Orthopedics program. I did my medical school in Ottawa and some of my, other undergrad and master's training in Ottawa. Currently, I'm in Vancouver, though, just on an elective working with the upper limb group here at Vancouver and at Royal Columbian Hospital. And in terms of kind of what brought me into medicine, I guess because really there's like two things. First, what brings you into medicine, then what brings you into surgery. Originally, I actually wanted to do law school, but it's a mixture of different interests that led me to apply to medical school, got in there. And then really, I liked working with my hands and actually making, not to say that other people don't make patients better, but to give, for example, an old lady can't walk because she's got a bad hip. Easy solution, you fix the hip, she can walk, right? Somebody breaks their arm, you fix the arm. So orthopedics has a lot of really good measurable outcomes. And so, I like working with my hands, the things intuitively make sense. If you do a lot of woodworking or if you do a lot of construction, you're kind of already halfway to becoming an orthopedic surgeon. So it seemed like the natural fit. And so I did that, and that's how I kind of got into where I am now.
Yeah, good stuff. Yeah, I mean, definitely if somebody has an injury or has a fracture, it makes sense. The natural thing, you're not gonna, tell them that it's all in their head or the pain isn't real. They literally broke something. So we have to obviously refer out, and those are the times when Dr. Hashem would come into play. Can you just talk to us a little bit? So now that we kind of know just a little bit more about you and kind of how you got into the field, specifically with surgery, as you mentioned, can you just talk to us a little bit about the anatomy of the spine, just to give some people who maybe aren't too familiar, just with how it looks like, and just kind of the basics?
Yeah, sure. So, I mean, I'll break it down simply. So, for those of you that have done anatomy courses and so on, obviously, you'll know it's a little bit more complex. But to keep it kind of simple, essentially, you've got bones, which act kind of like the walls around your spinal cord and your nerves. The spinal cord and nerves are what protect what help your body function, whether it's your organs, whether it's your muscles, whether it's the sensation that you have. And so essentially from your brain, the brain comes down to the spinal cord, and as it goes down the spinal canal, which is surrounded by the bone that we talked about, you have nerves that shoot off of the cord at different levels, and those affect different functions. Now within the spinal within the spinal canal, you've got these things called vertebrae. The vertebrae are the units of bones. You can kind of consider them like the bricks that make up your house. And then between them, you've got a soft tissue disc that allows you a little bit of flexibility so that the units can then move on one another so that you can, bend your neck, turn your neck side to side forward. So it's a combination of ligaments, bone, and discs that give you the flexibility. And then the different vertebrae have different orientations within their, some things we call facets that allow you to perform different movements in that way. So when you're nice, young, and healthy, you can do all of the moves. None of them typically bother you. But as you get older, just like as your engine in your car or any tool you use gets repeated use, it starts to wear a little bit, and you can start to either develop some arthritis, you get some erosion of the different components, and so then over time you can develop some degeneration. And so then the canal, which is normally filled with your spinal cord and some fluid surrounding it, can become kind of tighter, and then you can develop spinal cord problems. These would be kind of the progressive chronic ones. Obviously, if you're in a car accident, you have a big fall down the stairs or something and you break something, that can also lead to a spinal cord or nerve problem. And then the big thing that probably most of you guys hear about are people that blow a disc. And so what ends up happening is that disc that we talked about that is between the different vertebrae, again, pretty simplified, but it's filled in with this pretty flexible, gooey material that allows you to have kind of a cushion effect. But sometimes kind of like a jelly donut, when you squeeze it, the jelly comes out. And that's what can happen when you get a disc protrusion or extrusion, and then it can push up against one of the nerves or on part of your spinal cord. And obviously that can cause a lot of pathologies and can potentially be a surgical emergency, depending on where it is, or if not a surgical emergency, can still cause you an extreme amount of pain and discomfort. So that would, I say, be like kind of just a general, vague, simplified version of what the spine is and the spinal cord and the different nerves that come off of it.
Yeah, that's good. It's very obviously a detailed explanation on what's going on, and you kind of talked into a little bit of some pathology and what can happen when things aren't looking the best from an imaging perspective or even from an injury perspective. I think that's actually a good segue into one of the questions that I was going to ask you a little bit later on, but you kind of touched on it. So, I mean, obviously, when we see patients in the clinic, they always show us their MRIs and they say, hey, look what this says. It says degenerative disc disease. It says, disc herniation, or, you hear some of these things at the doctor's office where they say, they think of their back as being very weak because they're told that kind of jelly donut, their disc slips. So then they envision their back as being this very fragile structure that, if something like that happens and their disc slip, they're going to be, quadriplegic or something. How do you, and I know, of course, that's not what's going on when you guys are explaining it to them, but sometimes they may interpret it that just because of the differences in, sometimes can be differences in education level or understanding, and, us maybe not explaining things or not doing the best job at explaining things in layman's terms sometimes and using a lot of that medical jargon. So I guess the question is, how do you maybe navigate or try to explain, to these individuals who see some findings, some, quote unquote abnormal findings on imaging, and how would that relate or maybe not relate to the actual symptoms that they're experiencing?
Yeah, that's a great question that you have, and I wish I could say that it's super simple, but like most of the things, it's a little bit more, rather than black and white, it's a little bit more gray. So frequently, what I'll tell you is that as people get older, they get degenerative disc disease, and it's a bit of an absolute statement, but I'd say that most adults and people above the age of 40 have some, or even above 30, have some variation of some type of whether it's disc disease or some early signs of degeneration. It doesn't mean, though, one, that you're going to have pain at all or any issues in regards to that disc disease, and two, frequently, just because you have findings, it doesn't mean it's related to the pain that you have. So at least when we're looking in the clinic, the first thing we do is, it kind of doesn't really matter what to come in with. The first thing we do is we get your history, we get a physical exam. And then if those exam findings then correlate with something that we see on the imaging, it's likely that that's the cause of, it's likely that that's a contributing factor. But frequently, if I were to MRI everybody's spine, we'd find issues there, but it doesn't mean that you're going to necessarily have a problem there. And even then, even with a lot of people, some, with the same exact MRI, some people will have debilitating symptoms, whereas other people won't even know that they have a problem. But looking at the MRI, you're like, man, how are you even walking? Like, can you even feel your back or anything? They're like, oh man, I walk fine, I run fine, I do all these things. And the same exact patient in the other room with the same exact MRI, meanwhile, hasn't walked in years, is on disability, has to be in a wheelchair. So frequently the imaging doesn't correlate with the symptoms. So I'd say first and foremost, you need symptoms in a physical exam finding that then could correlate with the MRI for at least us as surgeons to want to do something about it. It doesn't necessarily mean that you can't have treatment for it, that we can't do physiotherapy, that you can't do modifications to your activities in order to improve that. But it's just to say that the MRI doesn't then, like, we should look at the symptoms and the history first before going to an MRI, not using the MRI as, oh my gosh, look, I have a bad L3 disc. It must be the reason that I've been having low back pain when, for example, you're also 100 pounds overweight, or you smoke, or you're doing, you have really poor posture, you have poor core strength. Those are other things that also contribute to that as well that you need to look into.
Yeah, no, that's a great point. I feel like a lot of people can just get caught up in that, defining themselves based on the findings on their MRI and, trying to use that as validation where, sure, it could be a cause or it could play a role, but it's just one piece of the puzzle, right? We're human beings. We're not just MRI or X-ray reports. There's so many other factors that can play a role in an individual's pain. And I think it's important that, physios and the surgeons and the doctors are kind of all on the same page with that versus being like, oh, your pain is exactly because of this. Because as you said, and as we know as well, the research shows that even as young as 20 years old, you can find degeneration in your spine. And sometimes the terms that we use need to be, explained a little bit more, because if we just say, oh, you have degenerative disc disease, if somebody who has never doesn't know anything about that, that sounds pretty scary if they're not in the medical field, right? Degeneration, that means, your back is just withering away. Disc disease, it's a disease, right? So very good to look at kind of the whole clinical picture, as you mentioned. So what kind of criteria or what do you look at if, or how does a day look like when somebody comes in who does have some back pain and maybe has some neurological findings? What are the next steps, or how would you advise this individual moving on if they come into saying, I need to have surgery, or surgery is the only option? How do you kind of navigate them and talk to them and figure out a plan for them?
Yeah, I mean, that's a great question. So I'd say that in spine surgery, there's some pretty clear indications on when somebody needs surgery. And usually they're pretty extreme. Either there needs to be instability of the spine. Usually that's either caused by, like the things we talked about, either extreme degeneration or some type of trauma. The other thing is neurological compromise. So, going back to the disc example, a disc is extremely painful. But usually that gets better over time, and the majority of patients will improve with or without treatment. The duration of symptoms, what we do for work, all these things kind of play into whether or not we may do surgery earlier than later. But if it's just pain, usually it'll get better on its own. And there are some substantial risks associated with surgery. So that's why we don't pull the trigger on that right away for everyone. But definitely if the spine is unstable, we need to do something right away. Or if the compression is significant enough that it's going to cause some neurological compromise, that is, one of the things your viewers might know are something called like Cauda-Equina syndrome, where your nerves are significantly compressed to the point that you can't urinate anymore, you can't control your bowel symptoms, and you get also neurological deficits in the form of your muscle control and in weakness. That's a surgical emergency. That's something different than just pain, right? So those are reasons that we would, certainly do an operation right away. For the most part, if somebody's just having back pain, the literature shows that a surgery isn't going to reliably fix that. And frequently people who get surgery after that still continue to have pain. If you have impingement on your nerves, it could be something that we look to surgery to fix, but equally, if not better, is frequently physical therapy or modifications of your activities, or losing weight or cessation of, some other activities or modifiable risk factors that, again, don't have the risks of surgery and will make you better anyways. So those are kind of the things that we look at to see whether or not surgery is something that would fix it. The other thing is that, like we talked about with the imaging again, a lot of people come in showing, significant degeneration or whatever, and they'll say, oh my God, this is the reason why I've got a problem. But if that level doesn't correlate with where your symptoms are, it's unlikely to be related to the problems that you're having. And so us going after that isn't going to help fix your problem. You're going to wake up from surgery, go through all the rehab, go through all the potential complications, and then probably still have the same issue that you had a few months before, going through all of the risks without a lot of the benefit. So those are kind of the things that we look at.
Yeah, those are some really good points that you make there for sure. So what if, I guess another question that relates to that. So say somebody comes into your clinic, into your spine clinic, and they tried physio, they've been in physio for a year or 6 months or whatever, haven't been getting better. Back pain is still, quite significant. Having some leg pain too, kind of, that typical sciatic, like nerve distribution, a lot of even leg pains, maybe even some more leg pain than back pain, but it's coming from the back. How do you, if you were to say all kind of conservative options have been exhausted, how do you proceed if you were to go with the surgery? And maybe talk to us a little bit about what are some different options that can be done in terms of the different types of surgery that they would need, again, depending on what level is affected.
Yeah, so I mean, first and foremost, like we talked about, is you need a pathology that correlates with your symptoms. So just because you have back pain, you've gone through physio, you've gone and done all these things, doesn't mean that there's necessarily going to be a surgery that we can even offer to help you, right? So I'd say like that's probably the first important thing to distinguish. The second thing is that a lot of people have, we try and separate things into leg dominant pain or back dominant pain. Unfortunately, back dominant pain doesn't seem to have as good outcomes as leg dominant pain. So definitely if the same person came in with a similar set of symptoms, but somebody's legs hurt more than their back did, that person is more likely to do better after surgery than somebody who comes in with back only or back dominant symptoms. So that's another thing just in terms of prognosis and for things to look at when you're looking at your risk stratification on whether the benefits outweigh the risks for a particular procedure. And then the third thing is, we go through and kind of like the first point, we need to make sure that, the symptoms somebody's having does actually correlate with what the imaging shows, because we want to make sure the surgery that we do for them is going to work. Now, in terms of the different types of surgeries we can offer, if it's a disc problem, so disc pushing up on a spinal nerve, for example, or pushing up on the spinal cord, we can do a discectomy where we go in and we remove that particular disc or debulk that particular disc of whatever's protruding on the spinal cord or spinal nerve. If it's a little bit more extensive than that, we can also do a fusion, especially if there's a little bit of instability there, or we need to take off a specific amount of bone to be able to do the amount of decompression that we need to do. Another option is we can also do just a decompression on its own. That doesn't necessarily have to do with taking out any of the discs, but what that does is it lets the spinal cord and the spinal nerves kind of become more free as we take out the surrounding bony structures around it. And then you can also, again, fuse the spine if you've done a certain number of levels that then require extra stabilization. Or if just it's the pathology that the person has is unstable in nature, then you'd also want to fuse it other than just decompressing it. So essentially we can look at review. If it's a disc problem, we can take care of the disc either by removing that disc or doing a disc replacement, which is something that people used to do, but it's much more restricted now with very specific patient population. We can do a decompression if we need more space in the canal or for the nerve. And you can either add that or add to that a fusion construct of some kind. So I'd say those are the typical back surgeries that you would see. And, we can do that in the cervical spine, thoracic spine, or in the lumbar spine from top to bottom.
Yeah, good. Yeah, that's a great explanation. That's a great point too that you mentioned, and something that I didn't know much about before we chatted. Before I started working with some of the orthopedic spine surgeons at the hospital, is one of the criteria that they look at is what's that ratio between the leg symptoms and the back symptoms before we would even consider surgery as kind of that later stage, if even at all. Because as you said, if somebody is just having pure back pain, they're not having any referral patterns, they're not having any red flags, no instability, as you mentioned, no caudate equina symptoms or problems with their bowel and bladder, then it doesn't make it appropriate to look at surgery as a potential option just because of some of those other factors. So I appreciate you bringing that up. And just mentioning that there is a better prognosis if somebody's coming in with more leg dominant pain versus back dominant pain, and they have some of those MRI findings, whether there's a disc herniation at a specific level, or there's some of those red flag findings that you mentioned. And another thing, that is good to bring up is just some of the different techniques there that are involved. So can you go over maybe in an OR, again, just talking about more on the surgery side, just for some of the viewers who maybe are interested in how that looks like. And I know they have animations and stuff online, but just for yourself and your experience, when you go into the OR and, the patient is prepared and they go through the surgery, what kind of equipment are you using in order to, let's say, you do the fusion or to do the decompression, and how does that look like just, in the field, in the OR?
Yeah, sure. So, I mean, depending on how many levels you're doing or where you are, you may or may not be wearing either like our loupes or microscope glasses, or we might actually use an actual microscope that we then put over the patient while we, dissect around the spinal cord or the spinal nerve. Typical things that we'll need, again, it's I may miss some specific named instruments here, but you need a scalpel and a hot knife that help you dissect the tissues. So that you can get down to the level of the bone. Once you get to the level of the bone, we can use either a combination of things called rongeurs, which are things that help us just rip the bone off or cut the bone off. And we can also use something called a burr, something that just rotates really quickly and burrs or just kind of peels the bone away or grinds the bone away, I guess. First step, get through the skin and the muscles. Once that's done, we then get through the bone. At this point, then we get to another layer of, again, it's going to be simplified here, but ligaments that we then need to get to that then protect the spinal cord. And in really elderly people, or in somebody who's been maybe doing a lot of weightlifting, or somebody with a lot of repetitive movement, or somebody with poor form, it could be hypertrophied. And so then we need to get through that before we then can get to the spinal cord, which itself is protected by its own layer of connective tissue, and then you have your spinal cord fluid around it. And so what we would do then is once we get to that level and we've taken out a sufficient amount of bone, we could then use some hooks to then either move the cord or the nerves if it's in the lower lumbar level, or if we're in the thoracic or in the cervical level, we don't really want to touch the spinal cord much at all. So then we would try and work around it to get to the disc in the front. The other option is we could also do that surgery from the front, like for the neck, where we'd make an incision here, work our way through the muscles, move the arteries and nerves away, and then get to the same level where now we see the bone and the disc, work through those levels, and then we can decompress the spinal cord, create that space we talked about, and then fuse it if necessary.
Okay. Yeah. Oh, good. Yeah, that's a really good explanation of kind of what's going on there. How long would you say the surgery lasts for generally, like for maybe a one-level fusion or a decompression or laminectomy or any of those?
Yeah, I mean, it really depends on what you're doing. So if you're just taking out the disc, it can be a pretty quick surgery. Some of the slick surgeons can get it done in like half an hour to 45 minutes. But again, it really depends on what level you're at. If the more complexity there is, the higher up, or depending on the level that you're at and what you have to do, it can really add time to it. The other thing that adds time to the surgery is the number of levels that you need to decompress. So obviously doing a 1 level is going to be a lot quicker than doing 2, 3, or even 5 levels. The surgeries that take the longest would be the reconstructive surgeries. So those would be, somebody who has severe kyphosis being like, classically hunched forward, or somebody who's got severe scoliosis where they're like twisted and there's a bunch of deformities in different planes. Those are the ones that take the longest because you have to really dissect a really large amount. You may have to take out, do osteotomies. And when we say osteotomy, it means to cut the bone in specific planes to then cause a realignment. And then usually we have to have a large fusion construct. So that is where we put a bunch of screws into the different portions of the bone and then use rods to help realign the spine into something that's more anatomical, where then we can lock it in place so that somebody can then have a much better posture. So somebody who's like, I don't know if you can see me on the camera, but like bent and in this weird position is now going to be in like a more straightforward position. But whenever you do a fusion, you're sacrificing flexibility to get that better posture or better position for the spine.
Yeah, good. Yeah, good.
Actually, I forgot what's your question. I was just rambling on there. So
No,
yeah,
that's good.
we can go over it again.
No, that's good. That's good. I like, that you kind of answer it and then you just go into just some other things to be mindful of, because that almost leads into questions of its own versus just following a very structured protocol. So generally, it depends on the level, is how long the surgeries can be, and also the type of surgery that you do and how complicated, if there are any other factors that are playing a role, can lengthen the time of the surgery. I guess that almost leads me into another question, just with regards to posture. You mentioned good posture, good alignment, and that's something that even in my channel, I try to get people to think about, is just, this perfect posture, this great posture doesn't exist, because we're humans. We're meant to move in different positions and be in different postures ever since we're young, but as we get older, we sit for long periods of time. It's hard to maintain that perfectly upright posture and back straight, shoulders back, that natural arch in your back, knowing that there's different, anatomical differences in individuals. But of course, you're mentioning postures that, are not necessarily related to what your static postures are, but actually what's going on within the spine. Like if somebody has a scoliosis of more than 50 degrees, or if somebody has extreme kyphosis and has a significant amount of pain, you can't tell them, oh, just try to sit up, or that's not bad posture, because it's not really their fault per se, or if it is a structural thing, or if it's a congenital thing from birth. So can you maybe tell us or talk to us a little bit about maybe that kind of what I mentioned, just about the posture and what your thoughts are around that? I mean, we know that people like Usain Bolt, he has scoliosis, but I'll have people come to me and say, I have scoliosis, it's bad, that's why I have back pain, but knowing that it's a little bit more complex. So do you want to maybe just comment a little bit about that, more on that posture piece, and what your takes on it are?
Yeah, I mean, that's where, when somebody does have scoliosis, it does have some structural problem where it's a little bit more of a gray area. But I'd say as a general rule, especially in our Western culture where you spend most of your time, sitting down, whether it's at work at a desk job, or, you're like even leaning up against something. For the most part, and myself included, we frequently have some bad posture. So, when I'm sitting down, like actually, I know you can't see it right now. I'm like sitting at the edge of my chair. I've got my core, like I got a good tense core, trying to get good core strength. I have my shoulders back, and I'm trying to sit as upright as possible. Right now, like that's fine. But over time, if I were to have a really poor posture, constantly be slouching, not really working on my core strength, much like, you and probably other people who watch this channel, most of us work out fairly regularly, and really try and work on making sure that we have a good, strong core, good exterior muscles to help support our posture. But a lot of people don't do that, right? So I think a lot of things aren't necessarily things you do in the moment. Like if I have bad back pain and when I'm slouched, I'm probably going to stop doing that. But I think it's people over a long amount of time who then continue to slouch, or don't have a good posture, or don't have good core strength, or don't work on their back muscles. And so what you end up getting is an imbalance that develops over time. And I think that chronic imbalance can then lead to people then having some low back pain that then doesn't really change when you go to a good posture, because now their natural posture is imbalanced. And so those are people who then are going to have to go kind of retrain themselves in terms of going to physio, going to work with a personal trainer, so that then they can either, whether it's lose weight, redevelop that equilibrium between their back and their core musculature, and then kind of redevelop now what a good, we'll say, equilibrium is a posture for them now at 40 or 50 or 60 or however their age is. So just in terms of, as a general rule, I think you should always work as much as possible on having a good posture, because it's not necessarily in that moment that it's going to hurt. Because when we're young, we'll just move, or we might not even have pain. But as you get older, that constant slouching can lead to whether it's deformity or a muscular imbalance, which can then cause you pain and trouble down the road. The second thing, going back to people who already have scoliosis or who have a natural deformity, I think for those people especially, you really want to make sure that you work on your flexibility and maintain that good surrounding musculature and good balance, because what that'll do is it'll actually support your, your spine and your, whatever other muscles, or excuse me, your other bones and other nervous structures and so on, as you continue to, I guess, age. And that'll really help you over time, because by maintaining that flexibility, maintaining that good core strength, it'll really delay when you may start to have symptoms. So instead of coming up at the age of 40 or coming up at the age of 30, you might be able to push it down later to when it starts to become a problem at 50 or 60. And even then, like you said, we have people who have scoliosis and don't even know that they have scoliosis, and they go their whole life not knowing they have scoliosis, and they die not knowing they have scoliosis and never have any problems in their lifespan, right? So yeah. It's a subset of people who actually end up getting problems. And so
sure.
I think as a general rule, try and keep a good posture, make sure you keep good core strength to help stabilize those what could otherwise become instabilities later in your life, to push those symptoms as far as possible.
Yeah. No, those are some good points, definitely, with regards to posture. The one thing that I would say, and again, correct me if I'm wrong, or just feel free to chime in with regards to this, is it's very hard for individuals to adopt that, that good posture. That, even for us, I think our bodies are very efficient, and they're going to kind of take the path of least resistance. So for me to maybe expect somebody to be sitting like this for 8 hours in the day if they're working, like, it's just not going to happen. They can buy the posture correctors or, activate their core all day. But I just think that, and again, this is what we learn in school, is the best posture is the next posture. So it's not necessarily, if you hunch over like this, that it's bad. It's that if you maintain that for 8 hours a day, you don't move at all. You don't take.
No, but that's also, I completely agree with you, Alex. So I think and this is where it goes back to our Western lifestyle of just being seated all the time. Like, man, in undergrad and in my master's and whatever, I'm sitting down for like 10, 12 hours a day, right? Even still when we're doing our operating, we're sitting down for hours at a time doing the procedure, or I'm standing literally with my neck down doing spine surgery where, my neck's in this abnormal position and I'm like sore for the rest of the day, right? Or, or you see some spine surgeons, or a lot of surgeons actually, if you look at them, they develop severe, kyphosis of their neck. They're like hunched forward, they lose a couple of inches, and they look like, like what you'd put as a caricature of like a really elderly person with a walker, but they're like much younger than you'd expect. And that's because they've spent, 10 hours a day for 30 years, just like looking down, right? So I totally agree with you, but this is where I just go back to you being mindful, trying to keep as well of a posture as you can. And when you can't do it, go around for a walk, take a break, make sure that you're exercising so that you can maintain that musculature. But I think the people that really suffer are the people that aren't mindful of that, and who just, keep into that position, don't exercise, aren't mindful, don't get up and take breaks, don't focus on that posture, because like you said, it's really easy to get out of it. And so I think you really need to be mindful and try to, as much as you can, maintain that posture, and to take frequent breaks and to do those things so that you can push as much as you can down the road the issues that you would otherwise have that you'd get much younger if you didn't do those things. So I completely agree with you, and it is hard. And I think that people who don't, or who only start to do that in their 40s and 50s have a lot more work to do than people who are doing that in their 20s and 30s and, you know, in early 40s.
Yeah, good points. Yeah, that's great to notice. I think, yeah, our lifestyle is very different than some, you know, some people out on the eastern side of the world. You look at places like India where people are doing, you know, maybe some places they might not have access to some of the technology and the, you know, innovation that we have here. So, for example, going to the bathroom, they just are able to do a full squat, right, and go to the bathroom. Whereas here, you know, we have our ergonomically designed toilets that, you know, and a lot of people can't even do a full squat just because of that. It's almost like, let's say with a sitting position, you're just in that 90-degree hip flexion, 90-degree knee flexion when you're driving, when you're sitting on the toilet, and there's not a lot of room for that variability that we had when we were younger, right? When you were younger, you'd be in all kinds of different positions. You'd be sitting cross-legged, you know, you'd be slouching, you'd be rounding, you'd be lying down in an awkward spot. But then as you get older, you just kind of almost conform to that rigid position that we're not designed to be in. So yeah, definitely, as you said, yeah, keep moving. And I think it's important to also just recognize that you'll slouch here and there, but as long as you can try to get out of that every so often, so you're not in it for a long period of time. Because some people can argue, if I'm, you know, in a military posture for 10 hours a day, then I'm probably going to have some pain too, even though that's good posture, right? That's upright, that's back straight, that's chin tuck, right? But because it's the common denominator is just the fact that it's sustained for a long period of time, that doesn't allow our body to take those breaks. Good. Yeah, good.
Yeah, I agree with you.
Yeah.
Yeah, you bring up a great point.
Yeah, I know we kind of went off on a tangent, but no, this is good. So, Dr. Hashem, talking a little bit about maybe going back to some of the surgery, and you know, when that surgery does happen, talk a bit about maybe the recovery that an individual would expect if they were to go along after the surgery. Maybe some things to be mindful of, you know, in the few days or weeks after the surgery to ensure maybe that some of the results don't go unnoticed, or you know, you take a few steps back.
Yeah, I mean, for sure. So, I mean, again, it depends on what kind of surgery you have, but let's say you end up doing a discectomy for a huge disc that was causing, you know, weakness, numbness, things like that. Usually those patients will, and for severe pain, those patients will be pretty happy afterwards, because the discomfort that they feel after the surgery is a different type than the excruciating, unrelenting one that they were having before. But certainly with a lot of back procedures, especially lower back, people have a lot of difficulty sitting down for the first month and sometimes even longer after the surgery. So we frequently tell people, limit your sitting to less than 20 minutes at a time. You know, and what they do is, you know, you start building up your endurance as you continue to improve and to rehabilitate. You know, sometimes we can have more or less restrictions on people depending on what type of procedure that they have, but definitely for the initial part, we try and get people to lie down and to minimize the amount of sitting that they do, because it puts a lot of pressure on their lower back, especially if you're slouching and trying to get into a more comfortable position. And I'd say that that's probably the biggest thing that people have. But much like most surgeries, you know, as you continue to heal, as you continue to improve and rehabilitate over time, that'll continue to get better. But really what you want to do is, much like everything, is make sure that you really work on the rehab. And honestly, for a lot of procedures and a lot of surgeries, this is outside of the spine, but you really get out of it what you put into it, right? So if you're doing the exercises, you know, you're making sure that you're walking as much as you can. You, even after you get better, you make sure that you're exercising to make sure you have good muscle strength. Those people tend to do better than people who just, you know, lay around after and don't really, you know, follow the instructions, don't really do rehab. You know, some people could still do great without doing any work, but as a general rule, I'd say the people who put in the work tend to do better. You know, but just to keep in mind, day to day, you may have worsening, or you might have a bad day with a lot more pain or a lot more discomfort, but week by week, you should continue to have improvement.
Yeah, those are some great points. Definitely rehab plays a huge role from that day that they come out of the OR, right? You know, we have to get them up and try to get them moving. as physiotherapists up when we see them on the floor, and get them walking and teaching them different positions and things to be mindful of when they're moving. And then over time, give them some exercise just to work on a bit of some of the range of motion. And then when they have their follow-up with you guys at that 6-week mark, where you guys do an x-ray and kind of see how everything's coming along, then usually that's when, some of the restrictions maybe are taken out, and then they can be a little bit more aggressive with the rehab, right? Because sometimes in those first couple of weeks, people really want to push it and, want to get back to lifting or working out. But, it's really important that you still, as good as that is, that people are motivated, you have to give that tissue enough time to heal. And something.
Yeah, just to add on that point. So there's two things. So just one, to bring a historical perspective into it. Back in the day, even just like, I don't know, probably like 30, 40 years ago, after people would have surgery, they just lay in bed until they got better. There's that expression, time heals all, problems. It kind of does, but you could speed it up with physio. You speed it up, and it's really changed. I'd say obviously I wasn't, practicing or even alive like 40, 50 years ago, but it's really crazy how the dynamic has changed, right? The number of inpatient beds that we have in a hospital is drastically reduced to what it was in the past, because people just assumed after surgery you'd need to be there for weeks as you got better. But now we're getting even people out the same day. So I'd say there's been a dynamic shift in terms of how we look at rehabbing patients and getting them moving. And now you literally see them in the PACU after they've been operated on. They're seeing you, Alex, and you're showing them exercises and what to do on the way out, right? Whereas in the past, you might have been like, whoa, buddy, you need weeks. Don't breathe too hard. You don't want to, you don't want to risk anything, right? The second thing I'd say is, don't forget. So in the post-op, not to you, but as in general, if we give you post-operative instructions, you got to follow them, because you may feel better before your construct or your bones are healed. And that's a frequent thing that we have where, for example, like we repair somebody's bicep tendon, and and they get that motion back and they just want to go back to the gym because they're like, man, I feel great, but it's not healed yet. And that's that risky period where if you push yourself too hard, or you push yourself beyond the parameters that we've set, that you can have a re-rupture. And the same is true of some back surgeries where we're waiting for the fusion to occur, or we're waiting for whatever it is to take. And so if you push yourself too hard, you can then break the construct. A little bit less so in back surgery than it is for other things, but it is an important thing to keep in mind. To if you give them, like if the physio gives them a hard stop or a hard limit, or if the surgeons give somebody a hard limit, that you really got to follow those and not push it, because there could be repercussions that you just don't know about, that we're worrying about, but that you're like, oh, I feel great, let's just push it and get better. So pushing through pain is not always the right move, depending on what surgery you've had or what type of surgery you've had.
Yeah, that's really good. That's good that you mentioned that, because I think that's not only in surgeries, that's just for any kind of rehab, right? Like with the specific bed rest, like specifically with back pain, people have pain. Naturally, you don't want to do anything because you think absolute rest or bed rest or just not doing those activities is going to make it better by just not doing it. But we teach them that whole hurt doesn't always equal harm. Just because you're causing a little bit of pain doesn't mean you're actually creating damage in the structures. And this would be more so, I guess, and what I'm saying is more in a rehab setting. Like if somebody comes in with back pain without the surgery, then I would kind of educate them on that hurt doesn't equal harm. Here are some things that you can do, and kind of gradually build them up, versus just instilling that fear in them and saying, oh yeah, you're right, you should avoid this or avoid that, or avoid deadlifting because it's going to hurt your back more, do these specific positions. And I think that can create some of that fear, because if people are scared to move, then they're not going to do anything, and then they're going to think that's going to get them better, but then it kind of feeds into that cycle. So that's a really good point that you mentioned that. And the other thing that you mentioned, another good point, is that whole, when people start feeling better, it's easy to just want to, oh, I feel great, like let's just go back to playing. And I look at that as like an ankle sprain, right? You're rehabbing your ankle, there's no pain anymore, you feel good. Okay, that means because I can do some of these exercises, I don't have pain, I can go back to playing my sport, not realizing those are two completely different parameters and environments, right? So definitely have to work up to that and be patient and trust the process.
Yeah.
Kobe Bryant says. R.I.P.
Yeah. Yeah. For RIP for sure, man. Yeah. Just the
Uh,
thing is for the most people, like, don't look to the sports athletes to see about how quickly you should or shouldn't get back to sports. Because the difference is frequently they'll do things that I would never recommend to you, right? Or that other surgeons or Alex as a PT would never recommend to you. It's only because those guys are being paid tens of millions of dollars to do that specific function that they're really pushed to get through the season or to, put their bodies on the line to whatever. The rest of us aren't getting paid hundreds of millions of dollars to do whatever, right? So you got to like take it, put things into perspective a little bit. What seemed super important to me in high school and university, I'm directly suffering from now, right? Like I used to tape up my ankles so I could continue to play soccer and volleyball, right? And now like, like TMI, but now I have ankle arthritis. And why did I need ankle arthritis, right? I wasn't getting paid $10 million to play in university, right? But it just, at the time it made, you wanted to finish the playoffs, you got to finish for the push, you felt selfish, didn't want to let your team down. But, again, if you're not in that super high echelon of particular people in terms of just, where you're going to be going for your career or where, all that money and stuff is on the line, your health is much more important than that. So just keep that in mind.
yeah. Yeah, no, I think that's good that you mentioned that. It actually almost leads me to another question slash comment just with regards to everybody's recovery is different, right? And everybody's goals are different. So when some people say, how long am I going to recover after this low back pain or this low back surgery or injury, it's all individual specific. And that somebody's recovery might be them just being able to walk with their partner for 20 minutes without having pain, whereas another person's recovery is going to be getting back into their sport. And I think that, it's important that us, like I know I see that a lot, us as physios, is we want to tailor our rehab to their goals. Because, I mean, as you said, like, is it worth it when you're younger to get, some of those injuries when you're older? For some people it is, right? Like some people, they would take that risk because them being able to garden in the backyard is one of the most important things that they can do. It gives them that sense of, independence, that they can do things on their own, that they're not relying on other people. So they really want to work towards that. Whereas somebody else might not even care about that. They might just want to not have any pain, which again, different kind of context, but you have to try to tailor your rehab and your approach to what they want. Because you can say how much you agree or you disagree with it, but there are some people, that means the world to them, and that can be the reason for them wanting to live even, like just being able to do these things that maybe we might find not silly, but just, they're really passionate about. So that's good. Okay, so let's talk a little bit maybe about the biopsychosocial approach, just switching topics a little bit. So obviously as a surgeon, you guys are looking more at the anatomical side of things, just with regards to the MRI. Surgery is kind of more can changes in the structure of an individual's spine or whatever body part by having surgery, can that change their function? When you have a fracture, of course, they're going to be in a lot of pain. You have to repair it to help them feel better. But what about some of those cases where maybe it's not that black and white, where somebody, like we were talking about, has pain and there may be an anatomical component, but what about some of the other factors? We call them the yellow flags, like the other things that we need to be mindful of. Did you guys learn a lot of that, like in school and even in your residency, when just looking at the other factors of an individual and their pain and why their pain is unique, even though they have the exact same symptoms as somebody else who has the same MRI findings?
Yeah. I mean, there's a couple of topics you bring up for that. The first, and I'd say it doesn't even necessarily need to be like great. Could be a black and white case. Somebody who's had a catastrophic, ankle injury or been in a big car accident. There are definitely factors that'll, are predictive, not absolute, but are predictive of if somebody does or won't do well, right? So, and that'll include, first and foremost, people's outlook on their injury. So people who, it's like an expression, but people who are Debbie Downers are not going to do as well as people who are optimistic and who are, trying to move forward. Same thing, usually if it's a workplace injury, it's notorious. There's plenty of studies for almost every part of the body, but for some reason, workplace injuries tend to do worse, right? Those people tend not to get back. They tend to be on disability for longer, or even may not go back to work, even for something that's pretty trivial. Sometimes, depending on the type of injury, sometimes people's sex can really make a difference, whether they're male or female. Usually, and this is a general rule, smokers tend to do worse on pretty much everything, whether it's in terms of functional scores, whether it's in terms of risks from the surgery or complications after the surgery. And again, I don't mean that as a judgmental thing. It's just that it's just something that the studies show. And then again, people's family support or support structures that they have will also impact on how people do after surgery or after a particular trauma. So, you've got the determinants of health, somebody's socioeconomic status, whether they're a smoker, non-smoker, whether they have good family support, good family dynamic, whether, and this matters more in the US, but whether they have a good insurance plan, things like that, that'll affect people, but also their own personal things that they could do, like in terms of quitting smoking, their own personal outlook, and then, things that they can do in terms of buying into their rehab, buying into the compliance of following the post-operative instructions and things like that. So definitely, if I had the same exact person in clinic, but one person, told me, they're not interested in cutting down on smoking. They've got all these other things going on. Their personality doesn't sound like somebody who's going to be compliant in the post-operative plan. That person's not going to do as well, likely, as somebody who's bought into wanting to do the rehab, is going to try and lose weight or cut down on their smoking before surgery and is serious about it, right? So there's definitely all sorts of things like that you said that both that'll influence somebody's outcome and definitely influence on my decision to do surgery on them as well. Because definitely somebody who's going to has all those yellow flags, you're going to really want to push surgery as far as possible because that they're going to have a lot of potential complications and outcomes. If there's going to be a negative complication, it's going to be in that kind of patient, and they're also the type of patient that may not take responsibility for for their own post-operative care and things like that, and try and blame it on you as the physio. Oh, you didn't show me, even though they missed all their appointments, didn't do any of the exercises, but they're going to blame you for not, because 3 months later, they're still weak, even though we told them it'll take up to a year to improve your strength, right? But they still missed all their appointments. Or, on our end, they just don't come to any of their follow-up appointments, don't follow any of the post-operative instructions, and then they come back with an infection, and it's our fault that they got an infection, not recognizing that the risk was higher because they were a smoker. Their staples are still in from 6 weeks after we told them that they needed to come out. They didn't take care of the wound, continue to do all sorts of things. So all sorts of these things play into different factors. But for somebody who's otherwise fairly healthy, and who's going to buy into their surgery, the important things are just making sure you're as healthy as you can be. You try and follow up as much as you can in terms of the physio and the doctor's instructions, and that you have a good positive outlook in that, and just know that things will get better, or even if things don't get better, we're going to be here to support you. The physio is going to be here to support you, and we're not going to just dump you and leave you to be on your thing. We're going to work together with you to get better. And just know that sometimes, though, there's not going to be a surgical solution to the problem that you have. There may not be a physio solution to the problem that you have, but that we're all going to work together to make sure that you're going to be as good as you can be.
Yeah. Wow. Yeah, you really touched on a lot of good points, and I think this is something that I noticed even when working with some of the surgeons. Is there's a lot of things that the physios and the surgeons are kind of on the same page with, which is nice, because a lot of physios don't work with surgeons directly, so to hear your thoughts and how they echo what we tell patients, it's reassuring, because sometimes you'll have patients who will come in and be like, oh, the doctor told me that I'm never going to walk again, or the doctor said this or they said that, and it's always like you wonder initially, you kind of wonder, maybe did they actually say this, or was this taken completely out of context? So it's, when you see it on the other perspective, it seems like we're really on the same page with a lot of things. The other thing I think is good that you mentioned is just yeah, the buy-in and the importance of just buying into the process, right? A lot of people want that quick fix solution. They don't want to go to rehab for 6 months. They want that medication that's going to make their pain feel better. They want that surgery that, they heard their friend had and had no issues afterwards. A lot of people don't want to put that work. So by being on the same page with the rest of the team and say, listen, like, you need to work on this, hopefully that can instill some of that, understanding that, hey, this isn't going to be easy. It's not just going to change overnight. But again, some people just, they don't want to hear that. They want to try physio for 2 weeks and say it's not working and quit. They want to, take the medications because they think that that's all they need to do. They don't want to exercise because what's the point? They don't want to stop smoking, stop drinking, all these things. But on the flip side, I think it's also important to know that, or be mindful of, there's a lot of other factors that could play a role in an individual's life, like stressors, family life, what's going on. Some people just, there's so much going on from an anxiety, depression perspective, so many other yellow flags that can heighten their pain or their beliefs, or maybe they read something on Google that said they have back pain, they're at risk for having cancer or something, you know what I mean? So I think it's important to use these appointments and these treatments with them to mention that these factors play a role and try to talk them into and educate them on the importance of, even changing some of their belief systems, or how can we modify some of the stressors. Some people will come in and say, I just want to be able to lift my grandson up, and I'm scared that I'm going to cause more damage if I round my back because I heard that it was bad for me. Just things like that. I think is important that we're bringing that to the table. And as you mentioned, some of those socioeconomic status or those other factors can play a role in why some individuals are very, as you said, Debbie Downers, or maybe look at the glass half full, whereas others look at it, or glass half empty, whereas others look at it glass half full. So, yeah, good point.
Yeah, like just to reiterate, there's modifiable and then there's non-modifiable risk factors. And the patient selection, for us, for a lot of things, it really has to do with patient selection for specific, grayer procedures. And really for everybody, what I try and do, and what I'd say, other surgeons I've worked with who I think are excellent, try and do is really work with patients to make sure that all of the modifiable risk factors are optimized, so that you can optimize somebody's outcome. But like you said, you have to recognize that there's some that aren't modifiable. Like if there's somebody who has a poor social situation at home, I'm not going to be able to fix that. You can't fix that, and they may not be able to fix that because of what's going on in their life and where they are. So it's just important to recognize that and to optimize as much as you can what you can optimize.
Those are great point. Modifiable versus non-modifiable, because if somebody has a genetic predisposition to something, or puts them at higher risk for a specific or just an anatomical variation, maybe in their spine, maybe they're more predisposed to having maybe they're predisposed to having pain, or even if somebody has a bleeding disorder, that can be they can be predisposed to complications potentially with surgery. So yeah, definitely lots of things that you can change, but a lot of things that you can't change. Good stuff. So, having been a part of, I'm assuming hundreds and hundreds of different surgeries, have you been able to maybe pick out some of those people that are able to, that will do well, versus some of the ones that maybe you see that won't do well based on even before the surgery?
Yeah, I mean, it was just like the things that we talked about, right? So the people who have a good outlook, the people who are bought in, the people who've actually tried to get, I don't, again, this isn't as a judgmental thing, but the people who've tried to get better and have put in the work, people who are reliable, like those are the people that, if you're measuring the same pathology in the same person, will tend to do well, versus the person who catastrophizes, oh, sorry guys, I'm ESL, catastrophizes everything, makes it, isn't going to take responsibility for the things that they've done, or tries to deflect or blame other people for things that they could have otherwise influenced. Those people, if they did that with other situations, are probably going to do the same thing with their problem or with their surgery. So that's where we just go back to patient selection, where I may be reluctant to do a surgery on somebody who has something that can be fixed, with surgery, with, if they have those behaviors because they're less likely to do better, or like we said, more likely to have a complication, or are going to be a bit more problematic. And, those are just things to keep in mind. But certainly if somebody needs a surgery, and, I'll do it for them. But that's just the thing for me, some of the things that go through my head when I'm trying to evaluate different patients. And again, I don't want to say it as something that's being judgmental about somebody or in a negative light, but it's just, those are the judgments that you have to do in your own head in order to stratify whether a patient's going to do well, what kind of follow-up you need to do with them, how much education you're going to need to, or how many times you're going to need to reinforce specific things. Like you had said, right? So we talk about a lot of things in the clinic with somebody, but somebody may take a specific word that you said and then make that what was talked about, missing the rest of the nuance that we had talked about for 30 minutes before and 30 minutes after, right? So that's where you just have to kind of read people and gauge who they are, and then try and tailor your explanations, tailor how much information you give them in terms of like pamphlets or follow-ups and things like that, in order to make sure that you've optimized everything that you can do to make sure that they do well.
Yeah, good point. Okay, stepping away kind of a little bit more from the surgery side, looking more at maybe a little bit of prognosis question. Can disc bulges heal on their own? If you see a disc bulge on an MRI, can that heal on its own?
So again, ignore the disc bulge. I've personally myself blown a disc doing deadlifts, unfortunately. So, but for most people who have symptoms, so develop acute symptoms from a disc bulge, right? 90% of them will improve or be better by the 6 to 3 month mark. 10% will still need surgery. Now, again, depending on somebody's level of pain, if it's like debilitating and if they have all these other things and it's not going away to the point that they're not contributing members of society, like they can't go to work, they can't take care of their family, those are other, softer signs that'll lead somebody to do surgery sooner. But as a general rule, 90% of people will be better within, by the 3 month mark if somebody has an acute disc that causes pain and sciatica, and symptoms. So we don't talk about healing in terms of does it heal, because it doesn't necessarily heal, but the bulge will resorb in terms of move away from the spinal cord and from the spinal nerve over that time. It may residually still be there, like if we did a repeat MRI 3 months later, but again, if they're not having symptoms, doesn't matter what the imaging's showing, right?
Yeah, that's a great point. Even like the resorption that you mentioned, because I was reading a study that showed that it seems like the larger the disc bulge, or you have the disc bulge, herniation, extrusion, sequestrations, different kind of levels. The larger the disc bulge, the more likely it is to just spontaneously resorb. So just, I guess, going back to what we chatted about, you have to look at not only that MRI, but all the other findings before you come up with that conclusion on how you're going to treat this individual. Because they may have had that before they even had any pain, and it may just have been an incidental finding. Like, it's hard for you to be able to know at this moment there's a disc bulge, because you would have had to do an MRI the day before you had the pain and the day after the pain to see if there was any change. So that's a really good point. So, Dr. Hashem, tell me just a little bit about what your thoughts are with regards to injections, whether that be cortisone injections or epidural injections, just as a method or a mechanism for pain management.
Yeah, I mean, that's a great question. A lot of people find a lot of benefit from the different types of injections. Again, it kind of depends on what their particular pathology is, but it's definitely an adjunct to helping the problem before surgery, I guess, is an option. So, sometimes the people are having a lot of difficulty. They're still having a lot of sciatica pain, or pain in a particular distribution. And so you can target that specific nerve with an injection. Or if, on their imaging, we can tell there's a lot of degeneration in that area pushing up on the nerve, we can see if they'll benefit from an injection. Because one, if they benefit from the injection, we'll also know that they'll benefit from the surgery when we decompress that area. But two, that injection may then help them do the physio that they need to do to then, like we had talked about earlier, just redevelop that strength, good posture, that conditioning, and kind of that equilibrium that they may never actually need a surgery. Or, we might be able to delay that surgery another 10 years or so. I mean, I'm just making up the how long it pushes. It's going to be very patient dependent, but, there's certainly many patients that we see when we're being consulted for surgery who tell us that they've been having injections for 10 years and that they've all been working great and so on. And the only reason they're seeing us now is because they haven't, either their disease has progressed or they've stopped working and so on. So it's definitely something that people can look into. I would caution you though, is that again, we need to make sure that there is a imaging pathology that correlates with their illness. Because if you have a good looking MRI, it's not necessarily that an injection there will help you, because if it doesn't look like the nerves being irritated by your spine, spine injection may not necessarily help. So again, it just goes back to, if you have symptoms in an exam that then correlates with the imaging, those are people that will likely benefit. Whereas if you're looking at the imaging and then trying to find symptoms that correlate with that, it's the opposite's not necessarily true.
And then leading to that question, or as a follow-up to that answer, sorry, when you're saying if somebody's coming in who's been having, injections for X amount of time, and they've been getting good benefit, is there a time frame where maybe you feel that the amount of injections that they're getting, like, are there any risks to having long-term injections, or maybe does that create a bit of a sort of dependency where they feel like they need these injections, or otherwise they won't be able to, do their day-to-day life, or to have less pain? Or how do you kind of talk to a patient that maybe comes in with that I need this mentality?
Yeah. So I mean, I don't. Again, what you have to look at is how you set up your patient expectations. What does the literature show? What do the typical patients benefit? And really setting somebody up and setting the expectations for what they can benefit from. Again, I'm not in my own independent practice yet, so I can't really dictate that particular management. But if I were in my own independent practice, I don't offer treatments to people who tell me that they need it. I have to think that they need it. And so, I wouldn't offer it to somebody who comes in thinking they need it. And a frequent thing that we have is, somebody will come in for an injection and say, oh, I'm doing great now, doc. Don't worry. Like, everything's fine. I'm still doing all my things, but I want the injection because last time it lasted X amount of time and I don't want, to feel pain again before it happens. And so I'm super reluctant to do that because, it may last longer, and with any treatment that we do, they're not risk-free. And so you need to make sure that those risks are outweighed by the benefits, because at the end of the day, it's on me if something happens, right? So just there's a couple things there. So first, somebody needs to, I think, have something that can benefit from it before I'll offer it. The second thing is that you really need to set expectations with people as to what the benefit will be and what that they can look at so that they're on the same page as you. And then the third thing is that just in terms of injections, and this is as a general rule, they tend to work well, but not everybody will find benefit from them. For the people that do find benefit from them, over time, they tend to become less efficacious. And so they tend to not work for as long. They may still work, but, instead of lasting for a year, they may then last 6 months, they then may last a couple months, and then they may not work at all. But for some patients, they may have repeated injections and none of them really benefit. But then again, we go back to the thing where patients who do benefit, where you see something on the MRI, it correlates with their symptoms, you do an injection and it gets better, those patients will probably get better if they do end up needing a surgery. Whereas the patients who, get the injection, it doesn't necessarily help, their pain is a little bit more vague in terms of what, in terms of making it correlate with what we see on the imaging. Those patients may still do really well after the surgery, but again, those patients may not because their pain doesn't follow that clear path that we had talked about in terms of where the imaging is.
Yeah, those are great points. Just setting those expectations, I think, is so important, right? For anybody's recovery or rehab. If somebody's just coming in because they've been getting it for the last X amount of years, that's not, those are their expectations that they want. But if you feel like maybe they don't need any more injections, or, you gave them a couple because it would increase that window that they can maybe participate in doing some more rehab because they're not having as much pain, and that nerve or that nerve root isn't as irritable, then that's the main goal of it, versus now just this being something that lasts. So, or is like a maintenance therapy, when people go to some providers, just like, I need to go here 3 times a week or 4 times a week just for maintenance purposes or something, you know what I mean? And then you're not giving them the onus. The rehab and the recovery is a large part of their responsibility. If they feel like they need to depend on you, it creates a bit of that, that dependency that can be a very slippery slope.
Yeah, and I mean, I'd say like sorry, just didn't mean to cut you off there.
Yep, no worries.
I'd say like for American viewers, this may matter a little bit more to you, because with a lot of people, what they'll do is they'll doctor or they'll physio shop, so, and I think it's really important, just to make sure everybody's clear, I think it's very important to get multiple opinions from people, because, either, maybe you may disagree, or maybe it's a gray area and you may have different risk tolerance than other people. Maybe other surgeons have different risk tolerance, or maybe, and again, I always think it's important to get a second opinion, because it could be that I've missed something, or somebody else gets to something that I don't, or the opposing, you go to see somebody else and they may miss something that I've caught, right? So I think that is really important. The downside, though, is that in the US based more private market, is if I tell somebody, hey, listen, if back dominant pain, it's probably not going to do well. I think you need to do some physio first. I think there's all sorts of things we have to exhaust, and here's the literature supporting that decision. But you're like, I don't really feel like doing physio. I'm just going to go find a surgeon who's going to just do the back surgery. Those, that may feel good to you at the time, because you're thinking, look at this clown. He's just too lazy. Doesn't want to operate on me. Listen, I'd love to operate every day for the rest of my life. There's nothing stopping me from that, but I also want you to do well, right? And so you may end up going to somebody and they may inappropriately operate on you, not because, they're not a good surgeon. They may be a very technically skilled surgeon, but you just may not find the benefit that you're hoping to get because of inappropriate patient selection, like we talked about. So I think it's important to get multiple opinions, so that you can get the lay of the land, make sure that nobody's missing anything, and choose the person who you think is going to do the best job. But at the same time, just watch out about shopping around for somebody who's going to do what you want. Because remember, we're like, this is my expertise, right? Or like for Aleks, he's his expertise is physical therapy and rehabilitating people. Just like, I don't go around arguing to my accountant what he should do and what, whatever, or like to the engineer who's building the house. Actually, this is what you should definitely put this beam here, without any expertise on the topic.
I watched the YouTube video.
Yeah, right. Like my house is just gonna fall down, right? So, and there's a reason that people are gonna tell me, this needs to be done in this specific way, and so on. So just remember, right? Whenever you go to see somebody for their expertise, you're seeing them for their expertise. And even though you may have, read up on it, watched a bunch of videos and so on, you may not necessarily have that underlying knowledge to know what the best option is. So all that to say, get multiple opinions, but just make sure that try not to stop for somebody who's going to do something that you want them to do just for the sake of doing it, rather than something that's actually evidence-based or somebody you're not comfortable with. Again, if you're willing to accept that risk, then all to you, but you just may not find the benefit that you're hoping for, and you may be putting yourself at unnecessary risks of surgery for a surgery that you may not need.
Yeah, that's a great point. Yeah, just because you obviously have your expectations that from a patient perspective, they have ideas of what they expect, but you want to go to somebody who's neutral, who's going to tell you, what the research says or what's best for you versus just what you want to hear. Because the person that says, oh yeah, we need to, do surgery, or you need to go to physio. If I'm a physio and I think that they've gone to physio for X amount of time, or this isn't a physio problem, then I shouldn't be saying, oh no, you need to go to physio, right? Because that's me looking after my interest versus what's best for the patient, right? Which is obviously what it comes down to at the end of the day, is doing what's best for them. A couple more questions, then we'll just wrap things up. Can you maybe give the viewers, again, a lot of people don't know just how a day in your life would look like, or any doctor, any orthopedic surgeon. So are you able to maybe just go through a day in the life for yourself?
Sure. I mean, it's pretty depressing life right now. So, I mean, what I do is, all right, so like I'll wake up at 4:45 in the morning. I'll do a workout, and then usually I'll be on my way to work probably by about 5:15, 5:30. Get to work at 5:30. I'll round on all the patients, make sure everybody's doing well, that nobody's got any complications. At the hospitals that I work at, from 7 to 8, we usually have some academic activities that we have to do. So in the extra time that I have, I'll usually study for those activities, or do a little bit of reading or practice, learn some new technique for any particular surgery that I'm interested in, or I'll prepare for surgeries that I'm going to be doing on somebody, that day or the next day. I'll have my work day, which is usually a day of clinic, a day of note writing, or a day of operating. And then at the end of the day, I'll usually review any inpatients that might have any issues, and then I'll go home, usually around 6 to 6:30, I'd say. Once every couple of days, I'll be on call overnight, which means I'll have to, whether it's operate or seek consultations or just make sure, we take turns among all the different doctors at the hospital, making sure that all the inpatients are doing okay, or that we do any of the emergency surgeries that need to be done in the evening. And on average, 2 weekends a month, 1 to 2 weekends a month, we'll do the same thing. When I get home, ideally, I like to cook dinner for my fiance. And then usually the same thing, I'll do a little bit more reading, prep for the day, and so on. I like to do my workouts in the morning, because usually at the end of the day, I'll be exhausted and I'm too tired. But if I don't do one in the morning, I'll try and get one done in the afternoon. And then usually whenever I have a weekend off, I'll admit, no alarm. I'll just wake up when I wake up, kind of like I did today.
Yeah, that sounds obviously very strenuous and, very, very long day. And I feel like it's very underrated what you guys do, because, as a resident, you're working, crazy hours, you're putting lots of effort and time in, and a lot of it goes unnoticed, or people don't really see a lot of that. And it's really, you start from the bottom, from med school, and then kind of building your way up. First year resident, second year, third year, fourth year, depending on what program it is, and you really have to put in the work to kind of get to that status. You have to, all the exams, all the extra time, all the extra readings on your own, and for the amount that you get paid while a resident, it really makes you scratch your head at, you're working 24-hour shifts nonstop, minimal sleep, and you're getting paid, from a financial perspective, you're getting paid peanuts. So I don't know if that's something that would change in the Canadian healthcare system, but definitely, a lot of what you guys do is, sometimes I just wonder how is it's possible just to work as hard as you guys do. It's really, really admirable. And you always have to try to take care of your health, no matter how much time you have, and whatever hours you have. It makes you prioritize and realize how important your time is.
It brings up a good point that you said, right? This goes back to like some of the non-modifiable risk factors. Like, it's technically modifiable. Like, if I'm telling somebody to get more sleep, but I get 5 hours of sleep a night, so like, how can I tell, you need to, like, what, quit your job, get a new job? Like, there's responsibilities that sometimes people have that are not actually modifiable, right? Sometimes changing a job or changing your social circumstances is just not something that's actually possible. Like in a work week, like my average Monday to Friday work week is about 70 hours of work. That's at the hospital, and that's not including being on call, like we talked about, overnight, and that doesn't include being on call over the weekend. It also doesn't include all of the work-related studying and preparation for operating, and orders and stuff that I do at home, or even notes that I end up doing at home in preparation, or in follow-up of things that I've done. So like an average work week for me is probably about 100 hours a week. Sometimes a little bit less, obviously, if I have a little bit less call, or sometimes a little bit more. And that's including all the things I do in relation, to my work. So obviously it's going to be less, hopefully, that's what I'm saying. Hopefully it'll be less as a consultant, because right now I'm taking care of, 3 to 5 surgeons' patients at any given time, when we're, taking care of somebody's team, because we're taking care of the whole trauma service, right? But as a consultant, I'd only have my own patients to see in the morning. And, obviously I'll be doing a little bit less, preparation and reading during the day, because then I can just focus on my own surgeries rather than everybody's surgeries. So, it makes a difference. But just, if ever you're at the hospital and you feel like shouting at somebody, just shout at somebody who's not a resident.
Yeah, I know. I feel like when you're working, I mean, it's tough for the patients too. Obviously, their situation is unique, and they're in their own bubble. They're in a lot of pain, and when somebody comes in, like sometimes they just want to vent to. But yeah, definitely realizing like, we deal with lots of very challenging individuals and lots of different kind of methods of communication for layman's terms, and definitely trying to be respectful and realizing that we're all just doing our best and doing our job to try to help the patient get better. And that's all we can hope for. But yeah, that's wow, 100-hour weeks. That's crazy. But you're almost there.
Yeah, it's almost there. I mean, it's different from place to place, right? Like I chose a place that works you exceptionally hard, but that's because there's in theory that comes with more operating experience. And so I chose to go there. And I'm kind of doing the same thing for where I'm choosing on where to go for my fellowship. So raised, like for your viewers, I come from a Lebanese household where things are pretty intense growing up. So for me, like this isn't not that much different. So no big deal. There's always been high expectations. I'm the oldest of all my siblings, so I've got to take care of everybody. So it's not a big change, but definitely, for me, I always try when somebody's having, even patients are being really rude or people or whatever, I just assume everybody's having, their bad day, because you never know what somebody's actually going through at home, what their social circumstances. If it's a repeated thing where they're always mean and always whatever, yeah, that's a different story. But I always just presume, somebody's either in a lot of pain, they're not normally like this, they're having a particular bad day, and I just try and treat everybody like that because, someday I'll have a bad day, and I'd want somebody to give me that benefit.
For sure. Yeah, that's a great point. Super important to have that empathy, right? Understand where they're going through and show that you're listening to them and that you care, right? Because that's all you can really do in those times when they're in a lot of pain or really struggling. Good. Yeah. Last question. Maybe tell us one thing about yourself that people don't know, either about yourself as Dr. Hashem or just as yourself as a person, not related to the orthopedic surgery side of things.
Oh my God, man, that's such a random.
I know. I didn't put that.
Why don't you tell me about this? Yeah. I'd say like something that people don't know about me is that I'm actually a shy person, which you don't know because I talk all the time and I talk to everybody about everything all the time. But it actually took me a while to get over that, and I think that my chatterbox nature now is a compensation for the fact that I just used to be super shy and like used to really care about how people would think about me, and it took a long time for me to get over that, so because when I tell people that, people are like shocked, nobody believes me, everybody thinks I'm making it up. But if you had to ask me on the spot, I'd say that's one of the things nobody knows.
Okay, that's funny because I was thinking of bringing that up for the first time of how we met, which is basically this guy just walks into the fishbowl, which is just a little area where there's a couple of computers, and just starts talking to everybody. No chill, like just whatever's on his mind. I'm like, who is this guy? And then we start talking. He starts talking about Serbia because obviously I'm Serbian, and mentioning these things about what he knows about Serbia. And I was like, boom. From there, it was an automatic friendship. Just because, yeah, he's super easy to talk to, and you'd never think that that when you mentioned that, I just kind of laughed because I never would have thought that, just because you
Yeah, that initial me
thought
talking, I
that.
actually have such anxiety. I'm like, oh my God,
Yeah.
you know? Yeah.
Okay. Yeah. Any like last words, maybe just with regards, I guess this is the last question, even though I said the last one was, but any last words, maybe, or just final remarks about kind of what we chatted about, just with regards to low back pain, surgeries, just orthopedic surgery, even in general.
Yeah, I mean, we talked about a lot of stuff, but really, I would say first and foremost, I'd say the vast majority of people with back pain don't need surgery, don't have any problem that requires surgery, and usually it'll just get better on its own. So, as a general rule, again, I mean, it's kind of medical advice, but not official medical advice. Consult your doctor, right? But in general, if you've got some low back pain, it's very, very common. Up to 50 to 70% of people, in some study I wrote once, I said that have low back pain at any given time over a year period, right? So if you've got some low back pain, you can take some medication for it, some Tylenol, some Advil, or other anti-inflammatory, especially if it's acute. And just think about what you've been doing and what you can do better. Are you having a bad posture? Are you at work doing something that's really repetitive? Or if you think that you're working out, because people have terrible form at the gym all the time and just don't realize it. So just try and actually be reflective and think about if there's anything that you can do. If it doesn't get better after a week or two of taking naproxen or like whatever, some anti-inflammatory and Tylenol, and trying to make sure that your posture is good, go see a physical therapist or go see a doctor, but really buy into whatever it is that the physical therapist tells you that you can work on. And for the most part, it should improve. And if it doesn't improve, or if it's a severe pain that's coming with red flag symptoms that we talk about, where you can't urinate, you're getting sensory deficits, especially in and around your groin or in your butt area, or you're developing actual weakness, then definitely go see a doctor right away, because then it might be that you've got a disc that's actually causing issues on your spinal cord or in some of your nerves. But if the doctor then does the imaging and says that there's nothing there, you can be reassured, and just know that it should get better over time, and that physiotherapy can really help. But just know that it's very few and far between the people that'll actually need surgery right away, and those will usually just be the people who have the red flag symptoms and so on. But when in doubt, just go see a professional, whether it's a physio, because they'll definitely tell you to come see us if they notice any red flag symptoms. And same thing, just, if ever you're really concerned, go to the doctors. But otherwise, if it's just a lot of back pain, if you don't have any of those red flag symptoms, give it a couple of weeks. Most things will usually get better by then. And then just try and think of what some of the things that you can do that are making it better, right? Are you doing things that are predisposing you to back pain? Are you really overweight? Are you smoking? Or is your occupation, like if you're a plumber, or like, are you always hunched over on your knees or on your back? Think of things that you can do better, but obviously you're not going to quit your job. So go see a physio, go see somebody who can then maybe help you with making sure your posture is good, maybe getting you fitted with a brace that can help offload some of that strain that you feel, making sure that your ergonomics are good at work and things like that. And, in general, those are things that can help.
Yeah, great. Those are some great final kind of points and take-home messages. Thank you so much, Dr. Hashem, for your time. Really appreciate it. Really appreciate you taking time out of your 100-hour work weeks to spend a couple hours with myself, and just hopefully get some education out there and continue to let people know some of the myths that we see day to day, whether that be on social media or even just fads or things that we believed in 40, 50 years ago. How there's lots of new research that's coming out that a lot of the things that we believed in then were actually not what we should be doing. So really appreciate you sharing your wisdom and your expertise with us, and looking forward to making another one with you, hopefully sometime in the future, if that's okay.
I'd always be happy to come back, and it's always good to talk to you, Alex.
Thank you. Okay.